Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am here with my beautiful, bodacious bombshell co-hosts,
Oh,
Dr. Susan Hudson from Texas Fertility Center.
Hello, I like being bodacious.
Doesn't everybody? And Dr. Abby Eblen from Nashville Fertility Center.
hey, everybody.
How are you girls doing today?
Good.
Feeling bodacious.
Or bombshells too. That's pretty darn cool.
Well, I was trying, most of the time our adjectives start with either S or F. And so I'm like, I got to pick a different letter. And so that's where that came from. I'm pretty sure Bill and Ted's Excellent Adventure like clicked through my head briefly to get bodacious.
I think that was the first PG-13 movie I ever saw in the theater.
I would believe that. I mean, at this point, I'm just going to start putting all my adjectives into a thesaurus or chat GPT or whatever. And that's how I'm going to start coming up with things. Although, to be fair, I have never in my life actually used chat GPT. And
Oh my
so
goodness. Carrie, you are missing out.
what am I missing out on?
Oh, it is so helpful. Like you can do all kinds of things on ChatGPT. Like literally, if you're planning a trip and you're like, what are like what are things that I need to see or do, or like I'm going to be in this country and I'm planning on traveling from here to here to here, it'll help you plan out your whole trip. You can write, like if you're writing an email to someone and you're like, okay, I'm not in a great mood, I need this to be softened, you can like put it in and say, please soften this, and it like magically happens. My husband like has used it, and this is really sweet. He was going to write a letter of recommendation for my son for his Eagle Scout, and
Uh-huh.
he used Chat GPT to make it. I mean, there wasn't anything that was untrue. It was just he needed some wordsmithing. It's a great thing
Huh.
to use.
I was definitely out with a girlfriend when she checked her text messages, having gotten a text from her, I don't know, 15-year-old son that was clearly written in Chat GPT of, "Dearest beautiful mother, I hope your evening is well. I would like to kindly request staying out until 10 p.m. tonight instead of being home at 9 or 8:30 or whatever it was." And I mean, it sounded like a Victorian proper child gentleman, whatever, was texting his mother asking for
But,
permission. Now,
but
it
the
was
funny
clearly
thing is, you
Chat
should have taken
GPT.
that and said, please put this in a wrap, and it would have done it for you too.
Yeah,
It's pretty
it was
cool.
clever. It
It's
made us
really
all
cool.
laugh. He
I
didn't get to
love,
stay out later.
I can't write poetry at all, but I love using Chat GPT for just funny poetry things. And you can tell, have it put all these different things in there, and like it just comes out so hilarious. I love doing it. Like we spent New Year's with some friends of ours, and we spend New Year's with them every year. And so I just wrote a poem about, kind of we've done this for like 15 years and the funny things that they do. And it's really funny how it sticks those things in there. Now, one time, and let me just say, we're all writing a book. ChatGPT is not going to write our book.
No.
I will say, but one thing in the book, I was trying to find the citation for it, and I knew it was in Fertility and Sterility, which is one of our main magazines that we use. And so I thought, well, this is great. I'll ask ChatGPT to, this is what the article is about, and to come up with a citation for it from Fertility and Sterility. So I thought with that information, it could come up pretty well. Well, it came up with a citation. You look it up, it had nothing to do with what I asked it about. It just pulled something out of
I,
the air. I guess it just said,
it's not perfect, and it's not good at math. I can say that. So if you're trying to do some sort of like equations or something like this, it's not very smart in math, which is odd because to me, a computer
It's a
program like
computer program.
math
you
is
think
the
a
first
computer
thing.
could add?
Like there's no art to math. It's equations. Like there is a right way, there is a wrong way, there is nothing in between. And so, but beware on math. But it is a fun tool. It's part of your armamentarium.
Yeah, and like we went to Scotland last year, and so I asked for some unique things, out of the way things that other people wouldn't know about, and so it was really cool. It came up with some pretty cool things. So I guess it just depends on how you use it.
Mhm. Very well then. So, do we have any questions this week submitted by AI or real people?
I believe these are real people.
Oh,
Um,
excellent.
Good.
so this is our question for the week. I'm almost 38 and have a 2.5-year-old, easily conceived. We've been trying ever since my son turned 1 with no success. About 8 months after seeing several doctors, I was diagnosed with celiac disease. I've been gluten-free for almost 10 months now. I did 1 round of IVF in February, had 15 mature eggs, 8 fertilized, 4 blasts, but none euploid. My RE said it was just bad luck. My husband and I have tested for everything else with no abnormalities. I did 300 gonal, 150 aminopure, cetrotide, and dual trigger. I'm about to do another IVF round. Do you have any advice or thoughts regarding IVF for someone with autoimmune diseases and inflammation? Would you do anything different for round 2? We will do ICSI, which we didn't do last time.
All right. What do you think, autoimmune queen?
Yeah,
Suggestions?
seriously.
So obviously you need to make sure that your celiac enzymes are in check. That's the biggest thing for that one. As to it having an effect on the I mean, you had 4 blasts. That's awesome. That's
Yeah.
fantastically phenomenal. Crummy that we didn't have any normals. I don't think you necessarily did anything wrong. I would definitely recommend taking some CoQ10 if you're not already taking it. It's not going to hurt. There's maybe some evidence that that might help improve outcomes when we're having, signs of diminished ovarian reserve. Considering using some growth hormone. Again, that's one of those things that your doctor may be in favor of or not being in favor of. But I've seen people who've had multiple blasts have abnormalities and then come back and sometimes it's just the luck of the draw.
Yeah. Sometimes a different pool of eggs potentially.
Yeah. And so those are things that can potentially help. But I would definitely do another cycle. I think, odds are definitely in your favor.
Yeah, there was a study, and you guys may remember that just came out. It may have been part of our CME, but it talked about how, if you do one cycle and you don't have any normal blasts, is it really worth doing another cycle? And there's actually data to show that it's just really like pulling the lever on the slot machine. Like Carrie says, you may very well come out with normal ones afterwards. And I've definitely had patients that have had, in this situation, had no normals. They go through again and they have 2 or 3 normals. So you just never know. So I would really encourage you, if you have the bandwidth emotionally, physically, and financially, keep trying, because you may very well do great the next time around and have several normal ones potentially.
Mm-hmm.
When you're looking at those odds of, even when you're under 35, half of your embryos are going to be chromosomally abnormal. It is very, 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 very rare for us to have people who have 10 embryos to be biopsied. That's not the norm. That is not the norm in any way, shape, or form. I would say most people have between 1 to 5 embryos to be biopsied.
Right.
And so it's only when you get into those higher numbers that when we say these statistics that they're exceptionally meaningful, because when you're looking at, 4 embryos that are biopsied, the difference between 100% and 50% is 2, and so it's
Yep.
it's hard when we're playing the numbers game and we have low numbers, but I would keep going.
Plus, even if you have just one normal embryo, and I always say this to my patients who are in this situation that don't have any normal, if you just had one normal embryo, you would be having a completely different conversation with your doctor, and you would have a really high chance, better than 50% chance, most likely, of having a healthy pregnancy. So hang in there, keep going. Good chance that you'll do better next time around.
Even ovaries are entitled to have a bad month every so often. So, all right, well, let's dive into our topic today, which is reproductive surgeries. And what a lot of people don't necessarily know is that when REIs are going through our training, we spend 4 years as OBGYNs and 3 years in REI training, and there's a fair amount of surgery that happens. And so let's start with the minors. And so when we're talking about minor surgery, we're generally referring to something that is a relatively short surgery, relatively low impact on the patient, usually a day surgery. You come in, you go out within the same day, doesn't usually require a whole lot of time off work, those types of things. So what is your guys' favorite minor to do?
Hysteroscopy.
Hysteroscopy.
So first of all, what is hysteroscopy?
So hysteroscopy is an outpatient procedure. Outpatient means usually in and out the same day, where you so there can be, well, there's office hysteroscopy and there's hospital hysteroscopy. There are some people, I think some of it, do y'all do office hysteroscopy? Carrie?
Yep,
We do a little bit, but not a lot.
Okay. So
I do a
the
lot.
general premise is going to be the same. If you're in the office, you may get some medicines to kind of relax you, versus if you're in the hospital, you're generally going to go to sleep. And we use a little telescope instrument to go through your cervix. So ideally no incisions, to go through your cervix and look inside the uterus. So hyster means uterus, oscopy means look. And then while we're there, we ideally can fix the things that are there. So when we're looking inside the uterus, things we're looking for. So one, we're looking at the shape of the uterus. So is the top of the uterus nice and smooth, or does it have a big indentation? Can we see the ostia or the openings to the fallopian tubes? That's important to know. Do we actually have a fully formed uterus? Do we see two ostia, or are we
Mhm.
for the first time identifying that, oh, when we thought we had a block tube on your HSG, it was actually because you have a unicornuate uterus, um,
Which is not a normal shaped uterus, right?
which is not a normally shaped uterus. We're also looking commonly for polyps. Polyps are little overgrowths of the lining of the uterus. You can also have fibroids. Those are other benign growths of the uterus, but if they're in places that are interfering with the endometrium, it can cause issues. Fibroids generally feel like if you cut open a tennis ball and the thing that's on the inside of the tennis ball, it's very firm but squishy. That's what a fibroid generally feels like. Or adhesions. So sometimes people can have scar tissue in their uterus, and we can fix that at the time of hysteroscopy as well.
So, Abby, if you go inside to do a hysteroscopy and you see something abnormal where it's out and floating and it looks like it's probably a polyp or probably a fibroid, and oftentimes we can look at it and have a pretty good idea of what it is. How do you actually get those out? Because you're going through a teeny tiny hole in the cervix. Like what do you do to get the ship inside, or in this case, out of the bottle?
Well, there's different kinds of tools, but as a general rule, we're able to put an instrument through our telescope. So there's another little channel that the instrument goes through. I prefer something called a MySure. It has an instrument that goes through. We have a pedal that we can activate, and it's almost like it looks like just a straight metal tube until the pedal's activated. And then there's a little door on the side of it. And I joke and say with my patients, it's like a little weed eater. You put it up right next to the polyp and it just sucks it in and chops it up and spits it out. And it's pretty safe in the sense that the blade is covered. The blade is inside the metal part of the tubing. And so it's a real easy way to get polyps out. And, it's real easy to kind of shave off the endometrium without taking too much. Some of the older things that we used to use, something called a resectoscope that some people still use, you have to be a little more careful with it because you can get pretty deep with it and you don't mean to. It tends to cause a little bit more burning or damage to the endometrium. And the MySure tends to help us just get what we need to get and not get anything else, which is really nice.
There's no heat involved with the MyoSure, so we're not worried about. So when we're talking about that resectoscope that Abby mentioned a minute ago, that was a little loop that used electricity, and so there was always some heat damage. Whereas the MyoSure, there's no heat damage.
There's another instrument out there called the Symphion, which is actually usually my tool of choice, that does have heat capacity, but the penetration is only like 0.4 millimeters. And so it's really good at nailing the one little bleeder that's blocking your vision of everything so you can keep working without doing damage to the uterus. So that's my favorite one. So okay, so we can morcellate or take little chunks out of the polyp or fibroid bit by bit until the whole thing's clear. What do you do? What do you like to use if you have a septum? So let's say you've got that big dividing wall in between two sides of the uterus that you can reasonably take away. How do you guys like to get that out?
I use teeny tiny scissors. So these are like literally teeny tiny scissors that are on a little device that you can introduce through the hysteroscope again. And then when it comes to a septum, you can use these scissors, and septums are fibrous, so they're more like celery, so it doesn't have a great blood supply. So we can use little scissors, and then when you do that, you can see when you're getting close to where you need to stop because you start seeing small blood vessels, and that's when you stop. And you can also use those same scissors when you're looking at adhesions as well.
So, what do you guys think about tubal surgery combined with hysteroscopy, meaning hysteroscopic tubal surgery? So, somebody comes in and one or both of their tubes is blocked, and to be able to be eligible, it would mean that they would both have to be blocked very proximally, meaning at the opening connection point between the uterus and the tubes. Do you guys do tubal surgery? Does anybody near you do tubal surgery of that type?
I've done that kind of surgery. I don't lean toward doing it too much anymore because IVF has such a good outcome and tubal surgery has not such a great outcome. Meaning, a lot of times I would do it along with laparoscopy because I would want to look at the far end of the tube to make sure it was fixable. So if the tube is damaged where it connects with the uterus and on the far end, generally we never thought that that was a fixable tube. That was probably a tube that just needed to be removed. But you certainly can put these little pipe cleaner things through the tube called Novi cannulas, and you can open the tube up. And sometimes you can have success opening that tube up. And of course, you don't know until you get in there how dense the tissue is or how dense the blockage is. The problem is the tube is so teeny tiny. And once all your fluid is gone and the cavity's decompressed and the tube's kind of sitting there together, a lot of times those tubes would just re-scar shut again. And so again, because IVF is so much quicker and so much more effective than tubal surgery, most people really rarely try and fix tubes. It's generally, if we go in for tubal surgery, it's to take the tube out, not to fix the tube.
Yeah, I've done them in the past. I really don't do them anymore. I had so many people. I mean, honestly, like to me, the best two outcomes were that somebody would get pregnant or they just absolutely would not get pregnant. To me, the worst outcome was ectopic pregnancy.
Yeah.
There were so many people who we would do this and then they would end up with an ectopic pregnancy, and then we end up having to either do methotrexate or other medicines or even have to go and do surgery and then remove the tube. So again, even where we are compared to 10-15 years ago and how good we are at doing IVF, it doesn't make a lot of sense. I think in there's always going to be some people who are doing that technology. There are still some people who do tubal anastomoses, which we may talk about in a little bit. But those are generally in very specific groups, and there's very specific groups that tend to do a lot of them. And so if you're going to have something like that done, doing it with somebody who does a lot of them is probably worthwhile.
Mhm. All right. And there's one other, it's adjacent to hysteroscopy procedures, but talking about cervical procedures. So sometimes you can have a polyp that's coming out of the cervix that we need to take out in order for us to get in to do whatever other treatments we're doing. Sometimes you'll have just a very, very stenotic cervix where it is just so tight and that hole is so teeny tiny that we cannot get anything, even our tiny little catheters through it. And in order to do that safely, we need to put you to sleep so that we can very gently dilate it up under direct visualization in a much safer environment where you are not going to kick us in the head because it doesn't feel good. And so that's very adjacent to hysteroscopies. Often if we're doing stenosis dilation, we'll put a scope in at the same time.
Yeah, or on the flip side too, Carrie, what I was going to say, I've had a run of people lately that have had cervical stenosis, but the good news was I was doing hysteroscopy on them, and a couple of them I didn't realize how stenotic they were. So by going in hysteroscopically, you have to open up the cervix about the size of a pencil to get the telescope in. And so it's sort of a beneficial catch-22 because in order to get the hysteroscope in, you have to dilate the cervix. And when you dilate the cervix, it makes a lot of the procedures that we do in the office, either IUI or IVF, where we transfer embryos in, a lot easier, actually.
Agreed.
Mhm. Absolutely. What are the risks of hysteroscopies?
So with all surgeries, there's a risk of bleeding, infection, damage to adjacent organs. So risk of bleeding with hysteroscopy, relatively low. Your risk of bleeding is probably highest with fibroid surgeries, second to septums, um, and very little risk with polyps or adhesions. Risk of infection is so low that it's actually not recommended for you to have antibiotics unless you have like a um, special type of medical conditions or something like that.
Yeah.
Um, yeah, and then there's always a small chance that during the surgery, either during the dilation, which is the time that's most likely to happen when we're opening up the cervix, or when we're doing a procedure inside the uterus, that there could be a small hole created in the uterus and something outside the uterus, actually in your belly, could get hurt. Now, that's relatively rare, number one. Number two, it actually doesn't cause that much damage to the uterus. The uterus is very, very forgiving. I mean, if you think about it, people have C-sections all the time and it
Yeah.
heals up, and we're talking about a very small hole.
I'm
Um,
sure. Yeah.
so it's really the most important thing is that it's recognized. When that happens, that means the surgery is over. So you're probably going to have to go back at some point a few months down the road after it's healed to get whatever hadn't been done. And if there was any concern about there being damage to anything in your belly, you may end up with a laparoscopy, and we can segue that way.
All right.
One thing before we
So,
segue to that, I was going to say, sometimes in some situations, you mentioned a second surgery. Sometimes if somebody has a fibroid, and fibroids are kind of like rocks, and if they're buried halfway in the muscle and halfway in the cavity, the deeper they're buried, the harder it is to get them out. And, as physicians, we do our best to try and shave them down and get as much of, even a little bit under the surface to get the fibroid out. But once the surgery's over with, a lot of times your uterus, when that fluid's gone, it's almost like your uterus kind of cramps and squeezes, almost like squeezing a toothpaste tube. And a lot of times, if there's a residual portion of that fibroid left, it'll push it out. Good news, bad news is we'll find that out. But the bad news is sometimes it takes a second surgery to go in and take that fibroid out. And, a lot of times I try and prepare my patients. If I think there's a reasonable chance for that, I'm like, look, I'll do my best, to get it all out. But sometimes it's just buried and you just can't see it. And the bottom line is we want to recognize it and make sure that we go back a second time to take it out. Generally, the second surgery is much easier than the first for most people.
So another thing that's unique to hysteroscopy is in hysteroscopy, the way we're able to see everything is we put fluid in your uterus, and we keep very good track of how much fluid is going in and how much is coming out. Now, nowadays, most of us are using saline or salt water to do this, and we can actually use quite a bit of that and have a relatively large, what we call deficit, before we have to stop. However, especially in those fibroid surgeries, there is a point where we have to stop because we want your body to be able to filter out that water without causing any problems with your heart or your lungs or your vasculature or anything like that. So there are points in this type of surgery that we have to stop, even if we're not
From a
done.
safety standpoint, yeah, we just have to
Yeah.
stop.
Again, that doesn't happen very often, most likely to happen in those fibroid surgeries because they can be quite challenging. I actually did one a couple weeks ago that, I mean, most of the time my operative time in hysteroscopy is less than 10 minutes, and
Mhm.
this surgery took me 2 hours. So
Mhm.
it was a huge
Surgery's
fibroid, and
hard
it was like a
surgery.
rock. We went through 3 myosure devices.
whoa, that's a lot of blade.
I've never gone through more than 2.
The other thing is there are some procedures where we'll kind of tell you straight up, this is probably going to take 2. If we
Mhm.
know that there's bad adhesions there, scar tissue,
Yeah.
if we know that there is a full septum that goes from the top all the way down to the cervix, those are going to take at least 2 surgeries generally to fix because enough fluid gets absorbed where we just have to stop for a safety standpoint. And at some point, it's really helpful to let it stop, settle, come back a month or whenever later
Mhm.
in order to finish the job and make sure it's done well. And there are some surgeries, particularly for adhesive disease, like I've had some where they were just flat cavities that we were opening up, and it can take several surgeries. Most of the time, like 2-ish, you're good to go, but just kind of know that sometimes we'll have to go back.
Yeah.
So talking about laparoscopy. So what's the difference between laparoscopy and hysteroscopy?
So laparoscopy is actually looking inside the abdomen. So you can look in, we can see the outside of the uterus, we can see the outside of the fallopian tubes. We can even look up and see the liver if we want to. So we can look all around there. But generally, as gynecologists, we're focused on the uterus and the fallopian tubes and the ovaries is what we're focused on.
But
And
sometimes we see something on the liver that's helpful.
yeah, every now and then we can see some things called banjo strings, some signs of infection, and we may understand better why maybe there's scar tissue in your abdomen if we see those. Sometimes it can be related to different
I
types of infection.
That is definitely a Tennessee thing.
That is a Nashville thing.
Banjo strings.
I've
Well,
never heard before.
actually, yeah, Florida, Tennessee. Yeah, well, it's southeast. Was that?
Yeah.
Banjo strings.
So,
So
what
what I
you're
was just gonna
talking
say,
about are those little adhesions that we can see on the between the abdominal wall and the liver, and so that can be a sign of prior pelvic infection.
yeah, one thing I was going to say, the one big thing that differs between laparoscopy and hysteroscopy is it's considered more of a, I guess it's not a major surgery, but it's a little bit bigger surgery than hysteroscopy because we have to actually make incisions, holes that didn't exist before. Usually there's one in the belly button, there's at least one in the lower abdomen, and sometimes there can even be up to 3. And these incisions are really small. They're big enough, again, to put like a something the size of a pencil or the caliber of a pencil into your abdomen. Generally, the one at the belly button is the one that we use to be able to look at what we're doing. The other ones will have things like a suction irrigator, they'll have a grasper, they'll have scissors, they'll have cautery, and it depends. The equipment that we use depends on the type of surgery that we're actually going to do when we're in laparoscopy. Generally, it's more like an hour to an hour and a half procedure. We fill your abdomen with gas, and it again, kind of like the fluid, kind of like the water fills your uterus and opens it up. The gas opens your abdomen up, so we can kind of really see what we need to do in terms of removal or cautery or whatever we're going to do with that particular procedure.
so what do we typically do to tubes when we're going in laparoscopically and we're talking about reproductive surgery? What do we tend to target around the tubes?
So when we're looking at fallopian tubes, one, we want to take a good look at them and be able to see them ideally all the way from the place they start in the uterus and where they come out. So we're looking to make sure that they are the right caliber. And they do get a little wider as they get further down, but there's something called a hydrosalpinx or swollen fallopian tubes that we know can have a really negative effect on fertility outcomes. Generally, if you have hydrosalpinx, we do recommend those tubes to come out. Um, we may put dye through the fallopian tubes to see if they are open or not. If you haven't had an HSG or the dye test, or if you've had a dye test and it said that they were blocked, we can recheck it at that time. We're also looking at the structure of the fimbria. So fimbria are the end of the fallopian tube, the little structures that should be picking up the egg after you ovulate. Sometimes the fimbria, it's named after fingers, and it should be nice and feathery and no, it shouldn't be clubbed. It shouldn't look like the end of your fist. And you want to make sure that it's free flowing.
So when you're looking at someone who's had prior tubal surgery, generally with either with the intent to intentionally block the tubes, or if they've maybe had an ectopic and so they've had prior surgery. If you know somebody's got blocked tubes and you're looking at them, what do you do with them in laparoscopic surgery? Do you do anything? Do you leave them? Do you surgerize them? What do you do?
Generally, if they're blocked on the far end, like Susan was talking about, where there's fluid there, we worry that can actually drop the pregnancy rate by up to 50% with IVF. And so, there's not a lot of great data in other ways of getting pregnant, but it probably is not good overall if you have a blocked dilated tube. Sometimes over time, those tubes can really get bigger and they can cause pain. So as I was saying earlier, generally we like to take those kind of tubes out. We don't like to fix those tubes. And so essentially we would leave your ovary in. So we wouldn't involve your ovary in it. We literally just go right underneath the fallopian tube, kind of parallel with it all the way down. And then right where it connects with the uterus, we would cauterize it, cut it, and remove the tube and take it out. And generally that's the major surgery we would do. Back in a long time ago, we would try and open the far ends of the tube open with cautery or something like that. And we typically don't do that too much anymore.
Do you guys see a lot of tubal reanastomoses being done? So procedures where a reanastomosis is taking taking one end and reconnecting it to the other end where otherwise there's been a big chunk taken out
Um,
or intentionally damaged.
I would say in our state in the past 4 or 5 years, we haven't done so much, but actually we were kind of the ones that did tubal reanastomoses. I mean, there's just not a lot of people around that do them, and they're actually really, really fun surgeries to do. We have to operate with the telescope, a microscope actually, and it's a really fun surgery. It's a long surgery, but generally, if you get a good anastomosis and you really feel like you've gotten the tube layers together really well, those patients actually do really well. The biggest issue, though, with those is the age of the patient. So a lot of times the patients that would come back for tubal reanastomosis, it would be because this is the second marriage and now they're in their late 30s, early 40s, and now they want to have a baby with their new partner. And just because of the age of the patient, not because of how long their tubes have been, cauterized or blocked with permanent sterilization, a lot of times those patients didn't do as well if they were in their late 30s, early 40s.
So
But I don't do this so much anymore.
yeah, I did tubal anastomoses in fellowship and training, but in private practice, I really haven't. In our area, probably we have a physician in San Antonio who practices kind of the NAPRO techniques and those types of things for natural kind of Catholic based fertility therapies, and I believe he does some. Actually, the people who do probably the most in the United States, are those reproductive endocrinologists in the armed forces. And
Oh, that's true. Yeah. Yeah.
that's actually probably the people who do the most tubal anastomoses, because it tends to be more of a covered type of thing.
Young population don't have coverage for IVF.
Exactly.
So what kind of laparoscopic surgeries do we do on ovaries?
So generally, if we're doing surgery on ovaries, it's because there's a cyst, some sort of cyst. So when we're talking about a cyst, we're talking about a collection within the ovary. It could be something that is full of old blood, which would be an endometrioma, a collection of endometriosis. It could be filled with other types of fluids. There's things called cystadenomas that are filled with different types of fluids that we would need to remove. Sometimes we may have what we call dermoids that can be filled with different types of tissue, like hair and fat and bone and different things like this. They're kind of icky, but we take care of them. And so a lot of those are done if they're causing a kind of structural abnormality that's either causing pain or it's just too big for us to get around.
Okay. There's a procedure called ovarian drilling that that all of us have heard about. All of us are kind of laughing at, but I
I've
still have
done
patients
it.
who
I've done it. You've
We've
done
all
it.
done
We've all
we've
done
all
it.
done it. We've all done it, but I will occasionally have patients who come back saying, "Hey, I have PCOS. Should I get this procedure done?" So what is it and what do you think?
I think ovarian drilling was really more of a thing back in the 80s and 90s, probably 90s, I guess, when fertility drugs were just not what they are right now. And so there were a subset of people that you just couldn't get to ovulate. I mean, early days of FSH, people didn't really know how to use it. And so I think for some patients back then, the idea was, and the idea still is, if you go in and you do ovarian drilling, which is where you just basically take a cautery that looks like a little needle point and you just jab it in the ovary and you cauterize and you try and go fairly deep so you get in the theca, the area that forms male hormones in the ovary, and you try and damage part of that actually. And so in a fair percentage of those patients, it's maybe, well, I don't know, fair percentage, but 30%, maybe 40%, sometimes you could get people to actually ovulate that had never been able to ovulate before. Sometimes it would be long lasting. More commonly, it would last for maybe 6 months or a year or something like that. But the hope is that you can get them to ovulate and get them pregnant. I don't really think it has a place anymore. I think A, we don't do laparoscopy as much, number one. B, we have much better FSH drugs. C, we have much better ways to help people ovulate. So I don't know that it really has a place anymore. I think the only person that might benefit from that is somebody that just absolutely, for whatever reason, does not want to do injectable fertility drugs and would be open to a surgical procedure to try and see, not to guarantee, but to try and see if it would help them ovulate on their own.
I think especially with the advent of using letrozole, I mean, between using letrozole and maybe like a whiff of a gonadotropin, there's a rare person that you
Yeah.
can't control that stimulation. I mean, there's going to be that, maybe one or two people a year that
You're
you're just
talking
like,
about surgery and there's no guarantee even if you do the surgery. So yeah, I agree with you. I'm not a big fan of it, but I think that was really kind of how it came to be back in the day.
yeah. And most of the people that I see now are people who are coming from outside the United States that may not have had kind of the fertility resources in their home countries. And they've had ovarian drilling, and now we're either dealing with the drilling didn't work or the drilling worked too well. And now we have some diminished ovarian reserve, which is what we're always worried about developing.
Yeah.
So when you're going in for a laparoscopy, and we talked about this a little bit with hysteroscopies, you do a diagnostic hysteroscopy or a diagnostic laparoscopy, you're just looking around. So when you're just looking around for a diagnostic laparoscopy, what is one of the biggest things in the fertility world we are looking for?
We're looking for endometriosis. And endometriosis is basically where the lining of the uterine cavity grows outside the uterus in place it shouldn't be. And really, laparoscopy is the way that you diagnose it. Sometimes we see little tiny implants that almost look like moles on your skin, and there's really no other way to image that than looking with laparoscopy. Sometimes they can be reddish lesions, sometimes they can be whitish lesions. Typically, we think of endometriosis as being an inflammatory condition. Even with mild cases, it can hinder your fertility a little bit. It doesn't really truly make you infertile, but it decreases your overall fertility compared to, how quickly it might make or how compared to how quickly your next door neighbors might get pregnant. If you have mild to moderate endometriosis, it might take you longer, basically. But the more endometriosis that you have, the more things can be all stuck together. Your tubes can be blocked if things are stuck together. Your ovaries don't function as well, and that the eggs release, but the tube can't get to it. And just it can cause a lot of pain when things are all stuck together. So, kind of the idea behind laparoscopy, particularly when we go in, is to look and see if you have some element of endometriosis. And if you do, we try and debulk you and get rid of as much of it as we can, either with cautery, or sometimes some people are able to kind of resect some of the endometriosis and remove it.
So at this stage, should everybody have a diagnostic laparoscopy?
Probably
Not
not.
anymore. Not anymore.
Probably not.
Statistically, if you walk into a reproductive endocrinologist office, I believe 60% of you are going to have endometriosis if we looked. And I mean, that's what the odds.
It's probably true. Yeah.
I'm pretty sure that's what the odds are. And so, but as our technologies have gotten better and better, and we've learned kind of how better to manage these things medically, it hasn't become it's lost its favor to go straight from your first consult to a laparoscopy.
Absolutely. All right. And what's the other big laparoscopic procedure? It's the only one that we haven't really touched on
Or the
yet.
big laparotomy that you might get.
So, so laparotomy, that's a whole different show. But laparoscopy, so you can get these hysteroscopically and laparoscopically. What are we going for?
Fibroids.
Fibroids.
Yeah. So here's a good time to bring in the robot, and I don't want to spend a huge amount of time on it, but what's laparoscopy versus robotic surgery?
So robotic surgery makes things so much easier. As a surgeon, when you sit down at the console, you can move your hands in the same way that you would move them if I were operating on somebody, like operating on their arm. But you're basically sitting in a console away from the actual table where the actual robot has the arms in there, and you can actually go in and you can cut, you can cauterize, you can sew, and you have the same ability to move your hands around as if your hands were right inside the abdomen doing the surgery.
So a similarity between the two are that your surgeon is going to go and put the ports in, the little incisions, where the devices are going to go inside your belly. With robotic surgery, you generally have incisions, more incisions on the upper part of the abdomen than just the lower part of the abdomen. And there usually are 4 or 5. I don't do robotic surgery, so please correct me if I'm not correct. Whereas with laparoscopy, we usually use 2 or 3 ports. And it does provide, as Abby said, better dexterity. We can kind of get into things more easily. We're not operating at the end of a long stick. but you do have to have specialized training.
Yeah, and the real difficulty too is if you have a lot of fibroids, you're using these little tiny instruments to cut and cauterize with. Whereas when we do it as an open procedure with a bigger incision, we can get to the fibroid, dissect it out much quicker. You go millimeter, literally millimeter by millimeter. Suturing, sewing it up can be a little challenging through the robot too. There's special kind of barbed suture that we can use now that prevent us from having to sew things at the end to keep the stitches from coming out, knots at the end, couldn't think of the word. So it's a great technique. And if you need to have a fibroid surgery done and you see a doctor that does really well, does a lot of robotic surgery, and that's their focus, then if they think they can do it robotically, it's much better to do it that way than it would be as an open procedure, because it's really the length of the incision that really causes the most discomfort. What we do on the inside doesn't matter nearly as much as what we do on the outside. So if you have a big long incision, your recovery period is going to be a whole lot longer than it would be if you're able to, even if you have 4 or 5 small robotic incisions, you're going to be able to get back to work and get back to life a lot more quickly. But essentially, the reason we take these fibroids out is if they're really large, if they cause you to have a lot of heavy bleeding, if they cause you to have pain. In the fertility world, we take out fibroids if they impinge or distort the shape of the cavity. The size of the fibroid, that's a little kind of vague. We all have sort of different preferences. Some data suggests that if you have a fibroid that's 4 centimeters or greater, it might have a bearing on your ability to get pregnant, even if it doesn't impinge into the cavity. But certainly fibroids that distort the shape of the cavity, those have to come out. And the problem with those is sometimes you can't get into those hysteroscopically because they're so big. They may span the whole width of the side wall of your uterus and poke into your cavity, but also be present on the outside. So those fibroids have to be approached in a way, either laparoscopically or with an open surgery where you cut on the outside of the uterus to get those fibroids out.
And one of the biggest differences between robotic versus laparoscopic is also cost and time and skill and experience. So when you've got a relatively minor surgery, like, a relatively easy ectopic pregnancy, a tube that's got to come out, like there's no real need to haul out the robot for that. But if you've got a big bad endo case where you're going to be in there for hours and it makes a difference, your dexterity and comfort and all of that, as a surgeon, that makes a huge difference. So if somebody offers to do a surgery on you and it's laparoscopic instead of robotic, there's reasons for that, because you don't want to have to haul it out if you don't have to. It's kind of like trying to kill a fly with a bazooka. It's just overkill.
Yeah. The one thing about robotic myomectomies, though, they can take a long time because sometimes you get in there and you find that there's more fibroids in there that you thought you would have. And they just, because you're going millimeter by millimeter by millimeter when you're cutting and sewing, it just takes a lot longer. But, even though you may be in the operating room, 3 to 5 hours doing a robotic surgery, the huge advantage is a lot of patients either go home the same day or the next day and really feel pretty good in a short amount of time. And I don't do robotic surgery anymore, but I have done it in the past up until about 4 or 5 years ago. And one time I was going in to do robotic surgery and I told the patient, her husband, I said, this is probably going to be a while. It's probably going to be 4 or 5 hours. And the patient was like, why are you going to take so long to do it, Dr. Eblen? And I go, well, do you want me to rush? So if your doctor takes 4 or 5 hours, let him take 4 or 5 hours. You want him to go slow and be very precise rather than rush and get done quicker. You're going to be asleep the whole time, so it doesn't matter.
All right, so we'll tie this up here because I think we could all probably keep going on and on about surgery for another 2-3 shows worth. But to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review in Apple Podcasts or Spotify. We'd love to hear from you. We're on Instagram, Facebook, and YouTube, so hop on by and leave us a like or a follow or subscribe or say hello.
You can also visit us on fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on our podcast anonymously for our Ask the Doc segment. Don't hold back. We love episode ideas. We love to know what you're thinking, and we'd love to hear from you.
As always, this podcast is intended for entertainment and not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye.